the cloud, or I would really be in trouble with Barbara. So we're going to talk about professional caring practices today. And if you think about that, that could be a very large range of ideas and concepts. So what I'd like to do is give you a little bit of foundation around the exam, kind of the why the exam is the way it is, and some of the components that are in the exam that are important. We'll work through some of the foundational concepts. I know you're probably all rolling your eyes right now, to really just kind of give context to what the questions might look like and really what we're looking for. We know our practice changes every day. It depends on the players. It depends on the staff that's there, who are the physicians, the family, and of course the patients and what they bring. And so when we think about professional caring practices, it's really encompassing all of that in order to have the best outcomes possible for our patients. Okay, not really sure why my computer's not moving. Just bear with me for just a moment. One second, you guys. I am so sorry, but it appears that I don't have the right piece up here. Just one moment, please. Again, I apologize. All right, I am working through this to see what the issue is. Okay, folks, let's try that again. I apologize for the inconvenience. All right, so let's talk a little bit about the exam. Essentially, 80% of the exam will be clinical judgment. So those are the things, the physiology, what things are we going to do based on disease states, what the patient's presenting, all of those pieces. And then 20% of the exam is around professional caring and ethical practice. So today we're going to talk about professional caring, and later on in the sessions, you will have a talk on ethical practice. So for today, we're just going to do professional caring. The breakdown of the exam, there'll be 150 test items. 125 of those test items are actually scored. So those are the ones that you're going to get right. The additional 25, and you will not be able to discern one from the other, will be for statistical analysis. So these are test questions that they're actually testing for future exams. And again, you won't be able to tell the difference between the two. You have 3 hours to complete the exam of the 150 test items. And for the most part, folks have found it very beneficial to do practice questions to really see how the material will be applied and then what kind of responses they are looking for from you. The basis of the test actually comes through the synergy model for patient care, and we're going to talk about that a little bit. For some people, they say it's common sense, and for other people, it really is enlightening for them to think about all the different pieces that go into the thought process and decision making um, that they never really thought about before. So, in essence, the synergy model for patient care was developed in 1992, and it really came out of a think tank, and it was done with AACN as well as the certification partners of AACN, and they came together and they decided that patient needs and outcomes must be the central focus of certification. In the past, it was really about the nurse's knowledge, the nurse's ability to have judgment, looking at the patient's assessment, the diagnosis, but it really didn't have a focus on family and community and really the multidisciplinary team and all the pieces. So it's a much more global perspective when we think about the critically ill patient. The key or underlying theme around the synergy model, or the key concept that you really need to keep in mind, is patient characteristics drive nurse competencies for optimal patient outcomes. So when you think about that, I think we do it pretty much every day. I don't think that we necessarily think about all the concepts involved, but I do believe that we do look at that. So, for example, if you have a patient who's on multiple support modalities, probably not going to give that to your brand new nurse who's first day on her own, but probably looking more to a senior nurse that has the competencies to care for all of those pieces. So, I think we do a pretty good job when we talk about drips and different things that the patient might need. But I think there's some opportunities for us to really think about what else is going on. How about the family that is just driving everyone crazy? And so our plan then is to just rotate the nurses through because nobody wants to have that patient or that family, I should say, more than 2 days in a row. So how do we think about those things and how do we match the competencies with the ultimate goal that we're going to have good outcomes? And when I say good outcomes, I'm really talking about yes, patient outcomes, but nurse outcomes as well. It's very important that the work that we do is fulfilling and that we feel that we made our contribution. So it's important not only for patient outcomes, for family outcomes, nurses outcomes, and really the team's outcomes. And it even goes as far, especially today, to say even the institution or the organizational outcomes. So much of what we do is rated. Grading now is 1 star. We're working on getting to 3 stars, and it's really looking at all of those components. So part of where synergy comes from was AACN's mission. And so the first part of the mission is patient and their families rely on nurses at the most vulnerable times of their lives. And really, if you think about it, most people, the last thing they want to do is be a patient and be experiencing a critical illness. Many times it's by surprise. That's not where they thought they would be today, but here they are. So, these truly are the most vulnerable times of their lives. Acute and critical care nurses rely on AACN for expert knowledge. So they are the leader in the industry. They are the gold standard for care and the influence to fulfill their promise to patients and their families. And then lastly, part of the mission is AACN drives excellence because nothing less is acceptable. So again, driving to those optimal outcomes, taking into consideration all the aspects of the patient and the system. When we look to their vision, AASN is dedicated to creating a healthcare system driven by the needs of patients and families, where acute and critical care nurses make their optimal contribution. This is probably one of my most favorite things. And if somehow this resonates with you, I think that's wonderful. So it's always looking to not only what's just best for my patient and my families, but my coworkers and the whole system as a whole. And where does the acute and critical care nurse get their information and how do they apply it? So what are the values that underline the exam? Well, the AACN values look at ethical accountability and integrity in relationships. So it's really about being a good person, looking at organizational decisions and being good stewards of resources, right? We really don't want to waste resources. We really know how precious those are and the cost of things, especially in the United States in healthcare. So we really need to be good stewards of our resources. Looking at the leadership, looking for folks that are going to promote lifelong learning, critical thinking, and inquiry. So your leader should be assisting in promoting lifelong learning, developing critical thinking skills, as well as inquiry. So why do we do the things we do? Is it because we've always done it that way? Well, maybe there's a better way, or is there any science to support what we're doing? So much of nursing has been, we just did it because, or we do it because we've always done it that way. But at AASN, looking at, are we really doing the things that matter and that really make a difference for our patients? And some of the things that come to mind when I think about that are things that really ensure that our patients are safe. And we've learned that because our outcomes weren't great, whether it be CAUTIs or CLAPSIs or HAPPIs, any of those hospital acquired infections or problems, and really looking to the evidence to see what is really best practice. And through those process improvements and looking at the research, that's where those bundles came from. And true, very important that we institute those to keep our patients safe, which is still underscored in AACN values and potentially could be seen on your exam as well. Excellence and innovation at every Oops, sorry about that. There's a typo at every level to advance the profession. So really looking at all levels, regardless of where you are, and working to the top of your licensure or accreditation in order to keep moving the profession forward. Collaboration to ensure quality patient and family focused care. So it's important that everyone is looking at the patient and that we all work together to get those outcomes. So when we look at the synergy model, and synergy is really how we apply concepts and appreciate the different characteristics of patients and of nurses, and how we bring those pieces together to match so we can have optimal outcomes. So when we talk about patient characteristics, we talk about both intrinsic and extrinsic. So, and they really are on a continuum from low to high. They can move back and forth, but really is pretty much a range. And each patient is individual and family and how they react to illness. And unfortunately, a lot of that is based on where those patients come from, the diversity in their background, in their living situation. All of those pieces come into play. So the first characteristic for patients is resiliency, and it's really all about the ability to bounce back. So how many patients come in and they've got multiple comorbidities, or maybe they're homeless, and how resilient are they versus someone, hello? Versus someone who can come in and has a great support system. So what's the resiliency? How well are these patients going to do? And many times, if we take a moment and pause in that initial assessment, we can really project how resilient a patient may or may not be. Vulnerability is the next one, and it's really looking at how susceptible the patient is to stressors, whether they be actual stressors or potential. What's their susceptibility? Are they going to be strong enough to overcome it, or is that just going to be the last straw? And again, that's part of the assessment. Stability. So, how stable is your patient? How able are they to maintain a steady state? So, for example, and we do this every day and we talk about it every day, they're critically ill, but they're stable for now, or they're very unstable. Really looking at those fine little things that make a big difference for patients, whereas other patients, they may not be doing great, but for the most part, they're holding their own. Complexity is the next one, and it's really talking about two or more systems being entangled together or coming together, and how do they interact to make our patient less complex or more complex. And if we think about it could be two body systems, right? So they could have respiratory failure and heart failure together, or they could have renal failure and diabetes. Whatever two systems, anytime you add another system, the more complex your patient is going to be. And not only does that refer to the body, but it also has to do with family as well. Some families are complex. Some families, there are no families. Some families are traditional families, and some families are not even blood families, but it's those people that are important to that patient, whatever that patient's support system is. The other complexity may be in therapy. So if we think about the cardiovascular patient, they may be doing fine on the balloon pump, and then the next thing you know, we need a ventricular assist device, and we're adding many more pressors. So what therapies? And oh, by the way, let's get CRT started as well. So multiple therapies would define your complexity as well. Keep in mind that complexity involves both the body, family, and also the additional therapies. The next patient characteristic is predictability. So can we predict a certain course? All right. So for the most part, patient comes, whatever their state of health is, they go for surgery. We predict that they'll do well, or we know this is going to be a tough one. And these are things that we do every day. We see patients coming in, the younger patients in good shape, we can predict that they're going to do well. The 104-year-old with diabetes and cardiovascular disease, previous stroke, those predictability factors may be different. And many times we're actually surprised at how well some of them may do. Some of the extrinsic factors in the synergy model talk about resource availability. So again, what resources are available to the patient, and those things are financial, psychosocial, living conditions, education, it really runs the gamut of any of those things that are considered resources. Family can be seen as a resource. Some family members may be more resourceful than others. There may not be any family members that are that can provide any resources or assistance for the patient. And even at times, it is the patient that is the resource and has obligations to other family members caring for them. And additionally, the community. In some communities, there are wonderful resources available for folks, and in others, there are absolutely not. So it's really finding what's available for this patient and what options do we see. And really, when I look at resource availability for the patient, I really think of our C3s, our social workers, our caseworkers that really try to put it all together. What is the best? What are the needs of the patient, and what are the resources, and how do we best match those for good outcomes? Another extrinsic factor is participation in care. So can the patient and or the family participate in care, and at what degree? So it wouldn't be the first time I had a complex patient and the family said, no, we're taking him home, we're taking him home. And we get everything set up, and all of a sudden it hits the family. Oh my gosh, we cannot do this. So how do we do that? How do we match those resources? How do we assist the family in understanding what those things are available? Some of the ideas that come to mind to really assess those people, to assess the family and the care of the patient is to have rooming in. So actually have the family member that's going to be providing the care and be there at the bedside and physically do the care to really understand what's involved. It also allows us to assess their ability to make sure that it is safe for the patient to be discharged. So all of those things come into place as well. How about decision making? That's another extrinsic factor. So, can the patient make decisions? And if not, is the family participating? Are they collectively participating or are they at odds with each other? Is there a history there? So, who can assist in decision making and looking at those decisions? Do we understand the needs of the patient? And then, how do we facilitate making the right decision so that the patient is safe and again, to have optimal outcomes? So, synergy model, we just finished talking about patient characteristics, and for some may seem very basic, and for others may think, well, never really thought about that. So, now we'll talk about the nurse characteristics. And underlying in the nurse characteristics is really a progression, and we're really going to move from the competent nurse to the expert nurse. And so, really, that too is a gradual process. Some move faster than others. It's really based on education. It's based on exposure and learning experiences, and the ability to actually have those experiences to learn and grow and move forward. So many times it's level of expertise that we're talking about here and where we are. So, are we a competent nurse or are we are an expert? And we may be competent in some pieces and some diagnoses and care of some patients, and we may be expert in others. And it's the ability to really match those pieces with our patients' needs. So another big part of what the nurses' competencies are really takes into effect healthy work environment standards. And again, healthy work environment is really a set of standards that really underlines the test as well. So these components are said to need to be present in the, sorry, these are meant to be present within the healthcare system so that the nurses can provide the best they can, identify the patient's needs, match those, and really utilize the whole multidisciplinary team to have good outcomes. So the first one is skilled communication. And interesting, when they first rolled this out, they looked at all of these and they said, well, what's the most important one? And for me, it was skilled communication. I'm a firm believer without good communication, we really can't even begin to have the others. So much of the work of healthy work environment standards actually comes out of the IOM report to Err is Human, and really looking at the ability for the nurse to speak up, to have safety concerns addressed, to ask those questions. And the environment has not always been conducive to that. And I will challenge that today we may find some of those environments as well. So it's the ability to speak up, to ask the questions, to clearly articulate your concerns, and really look at the bigger picture and decide where we need to go for our patients. So skilled communication, the ability to listen, as well as to be able to articulate those needs for our patients and families. True collaboration. And talk about true collaboration. Not only we're talking about collaborating with the family and the patient, but we're really talking about the entire healthcare team. Can we truly collaborate with physicians? Can we present the concerns of the patient? Can we present our concerns as professionals based on our assessment and what we think? Is it about evaluating orders that are written and deciding are these appropriate or not, or do I need to seek clarification? So true collaboration is at multiple levels. It's kind of with the patient. True collaboration also is our team of nurses that are working that day. How well are we working together? How well can we anticipate each other's needs? I can remember being a brand new nurse. Gosh, that was a long time ago, in an open heart unit. And I knew if Rosie was my charge nurse, she had my back. So it was okay that I didn't know everything because I knew I could always go to Rosie and she would have my back. If I said, oh, something doesn't look right, but I really couldn't pinpoint what the issue was, I know Rosie would be there to help me think through that and find out what was right for the patient. And I remember back then that wasn't true for every charge nurse, but it was for Rosie. Effective decision making. So, are we actually looking at all the data, which sometimes can be conflicting, right? You can look at some sets of data and say, okay, this is consistent with this. And then something else comes along like, well, that doesn't make sense. Let's go back and rethink this. So, effective decision making is the ability then to really assess multiple pieces of data, be able to synthesize that data, and then be able to make the right decision in the care of the patient. Appropriate staffing. I feel like we've talked about appropriate staffing forever. However, I think COVID has really given us the opportunity to really show what is the work of the nurse? What is it mean to not have nurses? And really, how are we going to come to this? And I think a lot of it for some was focused around money, but I think it's so much bigger than that. And I think the world is finally seeing that really without the nurses, I'm not so sure we can have hospitals. How are we going to do this? So you may have heard like in California, they have nurse patient ratios that are out there. So critical care, it's 2 to 1. It has to be 2 to 1, always 2 to 1. I don't know if that's what it is, but I'm using that as an example. Unfortunately, AACN and their healthy work environment standards really take that a step further. And so, for example, in California, for example, let's say in critical care, the nurse patient ratio is 2 to 1. Okay, well, that's fine. It's 2 to 1, but suppose they're all brand new grads on nights, including the charge nurse, and it's 2 to 1. Does that really going to make the needs and really give us the outcomes we're looking for? Or do we really need to look at what are the needs of the patient and then what are the competency of the nurse to meet those needs? I don't think I'd want to be a brand new nurse on the night shift all by myself with my folks I just graduated with and no other resource. And here we are to care for this group of patients that are all different and all in needing of different types of technologies and thought processes in order to manage. So, appropriate staffing is more than just the numbers. It's really about meeting the needs of patients and having the nurse with the right competencies to meet those needs. Meaningful recognition. Meaningful recognition is a very individualized thing. Some people really like the trinkets and those type things. Others, want to be recognized in a crowd versus others who would just rather a one-on-one, a short note. So whatever meaningful recognition is for that individual, we need to learn that individual, and that's how we do meaningful recognition. For some people, it's money. That's what's important to some people. But it's really from a leader perspective, knowing your staff and knowing what's important to them. And meaningful recognition is really about meeting that professional at their level, the way they want to be recognized, and then providing that. The last one here is authentic leadership. I think our leaders kind of get a bad rap. I think as I look back over the years, many leaders have come and gone quite quickly, don't really stay very long. I think it's a very, very difficult job. When we talk about the healthy work environment standards and we talk about the authentic leader, we're talking about the leader that actually role models and really strives to meet all of these healthy work environment standards. They're the ones that are going to set the tone for what the environment is going to look like. What does the communication look like? What does teamwork look like? So the leader and an authentic leader is someone who can walk the talk and really creates the environment so that our patients do well, that our nurses are satisfied, that other care providers, this is the unit they want to be in because there's true collaboration and effective decision making. So I've met a few leaders in my time that have been able to do that. I'll tell you, it is a lot of work. But the folks that work in those types of units are the folks that stay and are truly grateful for that experience. All right, so all of what I've just discussed was really the synergy model, the healthy work environments, is really focused on underlining the purpose of the exam. In other words, how all the pieces interact and how that exam comes together. So when we talk about professional caring, the things that come to mind that ASN's going to point out are clinical judgment, advocacy and moral agency, caring practices. What does that look like? Collaboration at multiple levels, systems thinking, and our ability to look beyond what is right in front of us. Response to diversity and how do we incorporate that into our practice? Clinical inquiry, always wondering what's next and where we need to go. And facilitation of learning. So I'm going to delve into each one of these a little bit further. So clinical judgment is really the expert nurse's ability to interpret multiple pieces of data. And sometimes those are conflicting pieces of data that I've talked about earlier. So the new nurse or the competent nurse may only be able to look at one small piece. And I can remember back in the day, um, we had this balloon pump or we had another piece of equipment attached to the patient. And as a new nurse, we focused on that piece of equipment. And I can remember my preceptors hearing it a lot saying, okay, I know you're focused on this piece of equipment, but we really need to be focused on the patient that's attached to the equipment. So really looking at the bigger picture. And, when we're new and we're looking at something, we're very focused. We only see that one piece. And then as we become more confident or more familiar, then we seem to expand out and can see more than just that piece of equipment. So again, clinical judgment is going to be in a range from the competent nurse to the expert nurse. We want to be able to demonstrate critical thinking. And when we talk about critically thinking, we're talking about the ability to anticipate problems. So you've assessed the situation, you're looking at what's going on right now, and then we begin to think, what might happen? What could go on? And what do I need to be prepared for? There was a patient recently who was in the OR. He was having a cabbage, I believe, and it was late in the evening and the patient still wasn't out of the OR. And we kept hearing every time they tried to close, they had to go back and reopen. They had problems getting him off pump, kept going into VTAC, and really just having a very difficult time getting this patient stabilized post-surgery. So the last that we heard was the patient was going to come out with an open chest. Okay, so what does that tell us? Well, if I have an open chest, I can't close it because either the patient is swelling or we're worried about bleeding. Maybe there's a coagulopathy going on. So how do we prepare for that, right? So the one thing is obviously our standardized defibrillator, external defibrillation isn't going to do for this patient. So where are the paddles? Where's the defibrillator? We need to bring those together and we need to be prepared. So not only do we need to do the regular things that we do to prepare for that patient, but identify the other pieces that we're going to need in order to care for this patient. Newer nurses may focus on current physiologic problems and the expert nurse would see bigger pictures, right? So they're going to look at, oh, what are the comorbidities? What is their support, their needs? How are we doing discharge planning? Are we starting that on day one? Are we looking to the future? One of the things in critical care that can happen, and I think there's lots of pieces that are involved, is you have someone that's critically ill and they were fine yesterday and here they are critically ill. and your family comes in and they're like, we want everything done. We want everything done. And many times, 5 days later, 7 days later, they still want everything done. Unfortunately, sometimes we can do everything and not have a good outcome, or we could do everything and have a great outcome, or sometimes we get stuck in the middle. Sometimes you can have a great outcome, wonderful. Sometimes you have death, and sometimes you get stuck in the middle. And the middle isn't such a great place. And I think it's important that when we're using our clinical judgment and we're working with patients and families, that we explain, there could be potentially three outcomes. They don't make it, they die, they do well, or they get stuck in the middle, meaning they're on a vent, they never wake up, and this is what their life's going to be. And I wonder if patients and families actually could really hear us when they make their decisions on what they can do, that they really look at that bigger picture. But for many, we're stuck in that right in the moment and we want everything done and really don't have the ability to think out further. So in clinical judgment, really helping the family see the bigger picture when it is very difficult. Clinical judgment includes acquired nursing skills, your experiences, your education, and evidence-based guidelines. So evidence-based guidelines becomes very important. So it's research that's looking at why we need to do the things we do and why we do them. But evidence-based, unlike research, really takes to account what is the environment. All right. So it says, that we should have 18 karat gold instruments. Well, that's wonderful, but does that work in this environment? So whatever that research is dictating, we need to look at how it falls into the environment. So it takes into effect the people in the environment, and it comes down to doing the best we can with what we have. Not all health systems are the same. Not all health systems have the same resources. So how do we take the research, apply it to our organization and our resources? And that's where your evidence-based guidelines are coming from. So advocacy and moral agency. So really at the expert level, we are really working on the behalf of others. And not only is it the patient and the family, but it's the other nurses as well. And in doing so, we need to be able to respect the rights, the beliefs, and the values really of everyone, regardless of how we feel and what our beliefs and values are. So it's important to look beyond yourself and to look at all the other pieces that may be affecting decision making or how we care for patients and families. We're going to advocate for the patient's family's perspective, even when it's not consistent with our own. So, an example of that would be in some cultures, they have certain rituals that they want to do, and you personally may not agree with any of that. Actually, it may be in direct conflict with some of your beliefs. At the expert level, we're able to acknowledge where we are, what our beliefs are, but also appreciate this family's need and what their rituals are. And as long as there is nothing interfering with the care of the patient or the science that we believe, we really need to allow that. So, for example, it might be that the mother has to put this ointment on the patient's hands and feet every day. That fulfills her need to feel like she's doing something, she's involved with the care, and the belief in her culture is this is going to make a difference. Well, as soon as somebody starts pulling out medications or something, we all get a little nervous and wondering, uh-oh, what are we doing here? And how is this going to interact with what we do? We need to investigate those things and we need to allow as much as we can. We need to give up that control as long as it's safe for the patient and the other therapies that we are providing. So sometimes we may actually need to adjust the rules, also known as policies, for things that are going to benefit the patient and the family. So what might that look like? So one of the things that pops up in my mind is visiting hours. Now, visiting hours have really Really been very interesting over the last few years. I think COVID has really um, been a very interesting expectation for communication and how we do that. So different from where we were immediately before. So many organizations had gone to open visitation. Families could come visit, come and go as they please. Some organizations were, that's what they promoted, that's what they did. I do not believe that was popular with 100% of the nursing staff or the medical staff, but it was really about having that communication with the family and really seeing what their needs were, and then matching that with the patient's needs and how can we accommodate both. So, however, during COVID, what happened? Nobody was in the hospital. Actually, it was just the nurses, right? Weren't even housekeepers. There weren't anybody. So nurses had to find another means then to really support families. And so that was that dedicated phone call time. That was those daily updates. And those were the pieces that we were trying to keep our families involved, keep them communicated with, get our patients connected with their families. iPads became very important at that time. And, thank God for the ability to actually physically see and talk to people with our technology that really helped with that. So we need to take that and move it forward. I can remember when visitation was opened up and then it got wider and wider. Nurses were like, oh my goodness, oh my gosh. I think some people truly enjoyed having less people around. It made life a little bit easier for some nurses, but for others, it made it much more difficult. And I think the message out of all of this is we really need to know what the needs of the family are so that we can work out a plan for visitation or for those phone calls. Maybe somebody's family works all night and, they can't be there but a certain time. So really understanding the needs of the family, and the patient, and then figuring out a way to do that. Would not be the first time that I stretched a policy or a rule to accommodate a family. I believe as long as it's well thought out and truly assessed, and that we communicate what our plan is, I think most times folks will go along, the institution will comply if it truly makes a difference for our patients and families. Always consider the patient support system in the plan of care. That becomes important. A newer nurse may think solely just about the patient, my patient, this is what I need to do, and forget that they're attached to a whole nother life outside the hospital, which includes family and friends and support systems. We want to empower the patient and family to speak for themselves. So many times the physician will come in, they'll talk to the family, and they're nodding their heads. The physician walks out, and the family has 1,000 questions. So, how do we assist them to be able to ask those questions? How do we prepare them? How do we encourage them to speak for themselves? And I'm sure you all know this, but sometimes it's a matter of just having them write their questions down or write them on the whiteboard. So it's very clear these are the questions the family has, and um, how do we get the family the information they need? The other thing you can do is invite them to multidisciplinary rounds. Some organizations have done a great job with that. It's a very standardized format. It's kept very short. It's 2 minutes. The families understand that. The success of that is really around describing for families and teaching them what the rounds are going to do, what the team needs for them, and then what items that we need to address right at that point or other things that we can save for later. So it's really about empowering patients and families to use their voice to get their needs met, as well as have an understanding of what the plan is. We know in the literature, the use of the multidisciplinary team will yield us better outcomes, decreased lengths of stay, it improves communication, and it provides for a better continuity of care. So, advocacy and moral agency for me is really about doing the right thing, the right time for not only our team, but for our patients and our families. Okay, advanced directives. Advanced directives become very important. I'm glad I get to talk about it from really the moral, ethical piece of it and not really the legal side of it. But advanced directives essentially allows the patient to express their wishes at the end of life. So what they want, what they don't want. Many times, families, even spouses, are in disagreement with what their loved one would want, but it's important that we hold true for our patient, and regardless of what's going on with the family, that we truly carry out the patient's wishes. Now, sometimes that's easier said than done. So I can sit here and say, no, we're going to do what the patient wanted. This is what they wanted. There are some physicians who will articulate that in their notes very clearly. This is what the patient wants. I have reviewed this with the patient. The family's in disagreement. However, this is what we're going to do. Unfortunately, in the United States, and our legal system doesn't always work that way. So once the patient is unable to speak for themselves, sometimes care providers will go along to keep the family happy. And the basis behind that are lawsuits. I'm not sure how well those carry out in court, but many times organizations will adapt to the family's wishes in order to avoid legal problems, or even just not that they would lose in court, but just that whole process and the cost of that as well. So for AACN and our moral agency and the care of our patients, we are always going to hold true to the patient's wishes. You're going to identify the decision maker if the patient's unable to make decision. And sometimes that's easy and sometimes that isn't. There are some patients who know that their family doesn't necessarily agree with what they would like at end of life. And so they'll designate someone else who maybe isn't a family member to be their decision maker. So it's very important that we know that we have those documents to support that so that we can carry out the patient's wishes. Another piece that becomes important during the advanced directive time is palliative care consult. Again, the whole thing, hospice, palliative care, a lot of people, the words alone just kind of set them off and they don't want to discuss it. They think it's just allowing people to die. They forget the piece about making people comfortable, and not only the patient being comfortable, but really helping the family as well. So it's much bigger than just allowing the person to die, but it's really about comfort and comfort for the family. I think it's important that we allow the family and the patient to know these resources are available, but the decisions are always ultimately their own. We need to address spiritual needs, whatever that is, for the patient and family, any kind of end of life rituals that need to happen. You know, certain religions, the one that I'm most familiar with is with in the Jewish population. Hasidic Jews believe when the patient's dead, everything has to stay. So, for example, a patient died, family was present, and as we were taking out the lines and everything, any blood that was on a 4x4 or anything needed to stay with the patient, that all of those pieces needed to remain with the patient. Normally we would toss those things, but it was important for this family and their culture that all of those pieces go with their loved one. So important to know what those rituals are, but more importantly is really to ask. That is the most important thing, is to really ask, have people know that their life rituals and beliefs are valued and that we are here to help them accomplish those any way that we can. The other piece that becomes really important is comfort. And so not only comfort for the family, but comfort for the patient, obviously, and the families included. So make sure we outline that families know the plan and that they know that comfort is a priority at end of life for their loved ones. So what are some pearls or some takeaways? We want to always be honest in communication. So if the family doesn't want mom to know she has breast cancer, that's really not okay. Those are not practices that we should engage in, and those could be things that you're tested upon. So again, thinking about the test, these are not things that we would do. So we would never keep a diagnosis from the patient. We wouldn't withhold any information from the patient. All of those things, we need to hold the patient first and deliver what's appropriate for them. Always maintain confidentiality. I think HIPAA has really caught on for many of us. So always be careful. Patient may tell you something in confidence, but they don't want the family to know. And that's okay. You want to always maintain confidentiality. Keep the patient safe. Always, always, always number one important thing, even on the exam. Remember, first order of business is to keep our patients safe. And then again, remember your resources. So ethics committee, who can consult the ethics committee? Um, for folks that work at Grady, they kind of do things a little differently. Ethics consult goes up through the medical staff usually, but just for the basis of this exam, it's much more broader than that. So the belief is that anyone, even the lady mopping the floor, can consult the ethics committee if they disagree with something or something doesn't look right. So anyone at any time can consult the ethics committee. Usually the first order of business with the ethics committee would be to look at, is this a legal issue or is it true an ethical issue? So tease those out. So if there's legal issues, then we're going to follow the legal pathway. But if it's truly an ethical issue where there's different opinions regarding how something is happening, then that indeed requires further analysis from our ethics committee, utilizing certain standards and principles that will allow us to come to a resolution. And again, you'll have more on ethics in a later talk that's happening in this series. So, caring practices, what does that really mean? It's really about being compassionate. It's really about having a supportive environment for both the patient and the family. The whole goal of caring practices is that we develop trust with the family. And sometimes that's can be a bit challenging, but that is our goal here is to develop trust with the family and obviously with the patient. Not only do we need to provide comfort for the patient, but we also need to provide comfort for the family. So whether that be through education, through knowledge sharing, through physical comfort, through alterations or special considerations for visitation, whatever that is, that's what we need to be focusing on for the patient and the family. Want to make sure that our families are updated. All right, so whatever that is in the organization that you work with, maybe there's one person that's designated and they're going to share the information with others, or multiple people you're going to share information with. Whatever that looks like, we need to make sure that our families are indeed updated. This gets a little tricky. Because we first of all need to identify who we consider quote unquote family. And when I say who we consider, who the patient considers. Sometimes we have friends that have taken care of someone for a long time. They've known each other for years. Those are the ones making their medical decisions who really don't have any relationship or any familiar properties with the family. They are simply a long-term friend. So many times we get legal involved to help manage those things, but those are appropriate. So no family doesn't necessarily mean that we don't have any blood relatives. Visitation, I think I've talked a lot about this today. No, for the exam, ideally it is open visitation based on what the patient wants and the patient needs. Okay. So it really is about identifying what the patient wants, looking at what is the effect when those people are at the bedside, how is the patient physiologically doing, how they're emotionally doing, and what does that look like? And really looking at the bigger picture to see how things are going. Sometimes of just having family members sit at the bedside, the patient's calm and is doing much better. Other times you can have a family member at the bedside that is completely agitating the patient. So sometimes we need to intervene, but for the sake of this exam, it is really what the patient wants and what the patient needs as far as their ability to rebound and to have a positive outcome. Some of the big highlighted pieces around family has family presence, and it could be during a code, during procedures, surgery, whatever that may look like. Um, for your exam, family presence, according to AACN and according to the literature and the research, is very supportive that the family be present. That becomes very important. So you need to know your organizational policies and procedures, but more importantly, the family has the right to be present. But what we need for families to understand is obviously what's going on, and we need someone to take care of the family member, right? So if you're in a code and you have certain people doing things, then and you have a family member who wants to be present, somebody needs to stay with the family member, update them on what's going on, and make sure they're okay. So you can't just like put them in a room and say sit in the corner and watch. We really need to have someone who's going to support that family member through that procedure, through that code, whatever that can be. Quiet environment is very important, so something that we need to really think about. Um, I think it gets pretty loud. Actually, it gets very loud from time to time. So I think it's important that we remember to promote that quiet healing environment and that alternative therapies are okay. We just need to look into them. And if there is absolutely no harm to the patient, we're not giving them some kind of medication that was brewed in the kitchen or whatever. As long as it's safe, there is no reason why we can't have alternative therapies. And really, if that's what the patient and the family want, we need to find a way to figure out how we can incorporate that into their plan of care. All right, collaboration. So that's a big one. Who we collaborate with. Sometimes we have to collaborate with the housekeepers or even sterile supply to get the things that we need. But when it comes to the exam and patients, and the answers on the test, we talk about collaboration. The nurse initiates collaboration, right? And that really starts on admission. We do all those screens and all those lovely questions that we have to do, but that really helps us identify the needs and then make the appropriate referral. So it is the nurse that is actually initiating collaboration. We want to include the patients and families in multidisciplinary rounds. Again, I don't see that at Grady in my areas, but do know that that does go on in other organizations, and they have really some very good outcomes. Again, there's structure around it, but do know for the sake of the exam that patients and families are included in multidisciplinary rounds. You want to prepare our patients and families for transitions of care. A lot of patients who know they're going to leave the ICU have a lot of anxiety about moving to the floor and how they're going to do. So it's important that whenever possible, we prepare patients and families for that transition and looking at what that's going to look like, describing that environment. May even mean having the family go down and take a look at where they're going, or at least explaining where it's physically located to kind of reduce those anxieties. Now, in the real world where we have no beds and we take whatever comes up and we don't always have a lot of time to really prepare patients, but when we do, we want to make sure that we address those pieces. We always want to seek opportunities to teach, to coach, and to mentor. And that's not only to our peers as nurses, but really, it's really the whole multidisciplinary team. And I know many nurses at Grady, and a lot of teaching places really have coached and mentored many physicians, all kinds of disciplines in order to the care of the patient. Also, under collaborations, not only do we look for those opportunities to teach and coach and mentor, but we also seek the opportunities to be taught, coach, and mentored. So it's a two-way street. So we owe that to each other to seek out those opportunities to teach and to share our knowledge, but we also must be receptive to be taught, coached, and mentored as well. And we want to make sure that there is value in consistent communication so that we value communication and that communication is the core of what we do. And without communication, everything really suffers. So not only do our patients and families suffer, but the multidisciplinary team, so that it's very important that we seek out consistent communication and we establish means for consistent communication. Okay, so systems thinking. So systems thinking is thinking much larger than the patient. It includes the family, and it's much bigger than just the family. It really focuses more to the community. It looks at more than just the ICU, but the transition to lower levels of care. It looks out outside of the ICU into the whole organization. So systems thinking is really more about the big picture, how all the pieces come together to work to get good outcomes. So we need to understand in systems thinking that there are going to be errors and mistakes may happen. And I have here may happen, but the truth is errors and mistakes will happen. We know that human beings make mistakes. That's just how we are. That's how we're constructed. And so what's important is how we react to those, how we share that information in order to improve systems so that others don't fall to the same issue. Right now Grady's going under this HRO, which is a high reliability organization, and the education's getting ready to roll out, but it's really talking about how, as human beings who are going to make mistakes, how do we develop the safest system possible? It's a very exciting time. I think it's a big shift in some of the thinking at Grady, so more to come on that. But back to your exam. So again, we want to be honest, don't cover up. And I know that's difficult to say based on what happened to the nurse at Vanderbilt, but remember, we're taking an exam here. And it goes really to our how moral we are and how we conduct ourselves in integrity. So very important. Errors and mistakes may happen. We know that. We're going to be honest and we're not going to cover it up. So if we make an error, we want to make sure that we alert someone as soon as possible. If there's something that we need to do to counteract that, we do it. And then we participate in a much larger group or a much larger view of how we can prevent that mistake from happening again. So explain, and we need a follow-up plan. What's going to change? Recently in one of the ICUs, there was an issue with heparin. So heparin is pretty standardized at Grady. It's pre-mixed heparin. Well, there were some parts of Grady that were mixing their own concentrations of heparin. And actually that led to 3 issues around giving the proper dose of heparin and titrating appropriately. So when they dug in and they found out, of course, the first nurse that was involved was just devastated. Oh my goodness, how could this have happened? Well, when they looked further, what they realized there was a systems issue. And so they fixed the systems issue. So now there's just one concentration of heparin that's utilized in every department so that we can avoid having that error happen again. But if that one person didn't speak up and the system didn't react in a way, how do we fix this from ever happening again? We would still have that error. So that follow-up plan is very important, and the sharing of that knowledge is important as well. So we're going to always assess for systems issues. We want a non-punitive environment. I think that's easier said than done. I think that's really a major culture shift for some institutions. At others, it's okay. But really, we want the staff to feel safe, to be able to articulate what has happened, what were the issues, come together as a team and figure out a plan to move forward. It's not about the individual, it's about the system. So if it happens to one person, it could happen to many. And that's a concept that we need to take. Sorry about that. All right. So, sorry, my thing got moved around there. Okay. So we're always going to look for systems issues. It's not about the individual. We want to make sure we use our safety tools. So safety is a very big part of your exam. So no unapproved abbreviation, must use your two patient identifiers. If you're having scanning and you can scan your meds and your patient and everything you do, you never want to bypass any of those safety mechanisms that have been put in place for you. So all those things become important. Other safety tools that you may be familiar with, I'll talk about heparin. That's a hot one these days. So we always have two nurses verify heparin. We also have two folks verify insulin. That becomes important. What is your prevention for CAUTIs? What does that bundle look like? Your VAE bundles, all of those specific care items that we do to keep our patients safe all flow into systems thinking and ultimately our safety tools that protect our patients. Response to diversity, I think this has really been very much highlighted lately in the media, in the profession, and really everywhere you turn today, there seems to be really highlighting diversity and really biases that we may not even be aware of. So we want to recognize and incorporate differences into a plan of care. So if there's something special for a patient, I shouldn't say special, that's not right. If there's something a patient needs relative to who they are and their life, then we need to try to incorporate that into the plan. So when we talk about diversity, age, gender, race, cultural differences, it can go on and on. The list is becoming very, very long these days as we recognize things that really make people different and that we need to appreciate those differences. Need to look at cultural sensitivity. So what are the beliefs that impact care? How do we incorporate those with ultimately having the best outcomes and keeping our patients safe? We want to modify the care to meet the patient's needs. We want to avoid stereotypes around culture, around race, around gender, around really around anything. So we need to meet the patient where they are, learn who they are, what their needs are, and their beliefs are, so that we can get them what they need so that they can get better and they can move on and have good outcomes. You know, pain, the expression of pain is a big one. So we want to make sure that different cultures express pain differently, and we need to be alert to those nuances. Privacy is very important. So, you know, it's kind of like you come to the hospital, it's like everything's fair game. So we want to remember privacy at all levels, and even things as simple as dietary needs become important. So how do we help create the environment for the patient in response to their specific needs? Clinical inquiry. So clinical inquiry just says, when we come to work every day and we care for patients, we really want to question our practice. We really want to evaluate practices. Why do we turn patients every 2 hours or every 4 hours? Why do mouth care every 2 hours or 4 hours or 6 hours? What does the literature say? What are our outcomes? Are we having issues? Are we having pressure injury? Well, why is that happening? Let's look at all the pieces. What does the literature tell us, and how can we affect our environment and our care so that we can improve? It's always about advancing the profession and moving forward. And without clinical inquiry, we lose that. So clinical inquiry is important so that we move the profession forward and that we're constantly getting better, no matter how great we are. So we want to be aware of current trends in the professional literature that allows us to stay current. We want to share best practices. So if you have a issue on your unit and you implement something, you really want to share that. You can share that in many of ways. AACN has a clinical scene investigator program that we were able to participate in, and I think we'll be participating again, where the staff actually identify a problem on their unit and then figure out a way that they can review the literature, find a best practice, looking at their environment, and figure out how they can manipulate or change the environment some way to improve outcomes. And so clinical inquiry is something that we should always be on our mind. We should always be asking that big question, why? 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 And that's kind of why well, it is why I started out the way we did, so that you understand the caring practices, and the exam itself is really based on the synergy model and healthy work environments, so that you understand the why, so that you're better prepared to answer these types of questions. So sharing best practices can be on your unit, in your hospital. Might be that you do a poster presentation like a lot of our new graduates do in the residency program, and then they're actually taking those poster presentations and they're presenting them at different conferences around the country, which is pretty exciting. Clinical judgment and clinical inquiry cannot be separated at the expert level. So at the expert level, when you're working at the top of your game in clinical inquiry, you are always questioning. You're always looking for the why. You're always trying to figure out, how do we do it better? Why do we do it this way? And does it make a difference? So AACN does provide practice alerts. If you go to their website at aacn.org, there's a plethora of information there, but you will see that there is practice alerts, and practice alerts take the most current literature, and it kind of is a very, very concise way of a review of the literature and different things to implement for better care. So two of the practice alerts that are out there are around family visitation that come to mind around this piece. Also, use of the multidisciplinary team. So there's different practice alerts for different things. I encourage you to look at those, because those are the latest and greatest, and those are the things that we need to be doing based on the evidence that have proven outcomes for our patients. So I kind of got ahead of myself here. So evidence-based practice alerts, family presence during resuscitation and invasive procedures. There's also visitation in the adult ICU. So clinical inquiry. So if you have that why question and you need to say, hey, why do we do it this way? I think we need to do it this way. Here's the sequence of steps that you would follow. So you want to include your multidisciplinary team. None of us really works by ourselves. Really, it's the collaboration amongst the multidisciplinary team that truly makes the difference for our patient. So you want to include your multidisciplinary team. Literature review becomes important, and it's important to know the level of evidence. So the highest level of evidence are randomized controlled trials. So the research trials where certain pieces are blinded, and certain key pieces are put in place so that we have an effective quality research trial. So random control trials are your highest level of evidence. The next level would be systematic reviews and meta-analysis, where they look at, they search a topic and they break it down and they review all the literature, current literature that's out around that topic, and they do a review of the literature. National practice becomes important, professional guidelines. So things like ANA standards of care, AACN standards of care for the critically ill patient, all of those things come in place. What does your state hold true? So what does your state nursing license have to say? Are there any particular things? One of the big things in the past was the use of propofol and or Diprovan as a brand name. Who could give it, who could not give it? So depending on where you're working, you need to know what your state requirements are, and you need to follow those guidelines as well. Unit-based counsel is a great place to go. And then the way you actually create an environment of inquiry is to use why. It reminds me of a 2-year-old who's going to say why, and drive you crazy. But if you keep that in your mind and you'll always know the why, chances are it'll give meaning to what you're doing and consistency will be coming. I'm a firm believer that when we roll something out to the staff is that we really need to have staff understand the why. And in order to understand the why, or understanding the why allows us then to accept the new practice and then continue that practice based on the current literature. So always want to create that environment of why. Facilitation of learning. So we want to identify barriers and preferences to learning. Again, many of us and many institutions do this on admission. We identify what are some barriers, how does the patient prefer to learn. Generally, a very general statement, one of the best ways is to do teach back. So if you're teaching the family something, to have them do a return demonstration is usually one of the better ways in the literature to be sure our families understand. We tend to dump a ton of information at discharge with our patients and families, and they are just so overwhelmed by the whole thing. Chances are they don't remember much at all. I know on 5A, many patients and families will come back the next day or the following day, and they are asking questions. So they got home, they tried to figure things out, thought through it, and then now they're coming back with questions. So real important that we don't do like an educational dump, and that our education is ongoing continuously, and it's continuously building. So we want it episodic versus all at discharge. If you need a medical interpreter, by all means, you need to access those resources within your organization. Remember, family members and friends are not medical interpreters, and this is a very big deal, and this is a legal issue as well. So people need to be certified. So it is not okay to rely on the 16-year-old daughter or the 25-year-old son or the brother or the sister. It must be a certified medical interpreter to ensure that the right message is being shared. And again, as I mentioned already, teach back method is really one of the most widely used and accepted methods to really see if your patients and families understand. So staff educational needs, this is important. We never accept patients that you have not been trained to care for. So if they're telling you you're taking care of a balloon pump today or a PA catheter, or you're going to do code ice or CRT and you haven't done it before, absolutely. If you do not have those competencies, then you do not care for those patients. So the first thing you're going to do is report it to the charge nurse and request reassignment immediately. And sometimes that's not possible, right? So you're going to request it. If it's not possible, then that charge nurse is going to figure out some means by which that patient's going to have those needs met, but it will not be by the person who doesn't have those competencies. Do not cover for breaks if you're not trained to care for all the pieces of that patient. that becomes important as well. You want to demonstrate competencies to care for specific patient populations. So if you've been trained on ECMO, by all means, you can care for those patients, intra-aortic balloon pump, PA catheter, code ice, Arctic sun, any of those things. You want to make sure that you only accept patients that you have the competencies to care for. Okay, so I have some practice questions here, just doing a time check. So we have some time to go through some practice questions here. So a nurse is having, whoops. Okay, a nurse is having difficulty with a patient's family. Requests assistance from an experienced nurse. So the patient's having problems with a family, and she requests assistance from an experienced nurse. The best approach for the experienced nurse is to A, offer to speak with family, B, advise the nurse colleagues to ignore the family's behavior, suggest the use of active listening techniques, suggest the patient assignment be changed. All right, so we're going to go back to the core of the question, and it says, so a nurse is having difficulty with a family's request and requests assistance from an experienced nurse. Okay, so she's going to ask for help. The best approach, offer to speak to the family. Is that really assisting the nurse? No, so that's not the answer. Advise the nurse colleagues to ignore the family's behavior. No, that's absolutely not one we're going to do. Suggest the use of active listening techniques. Maybe. Suggest that patient assignment be changed. All right, the answer here is C. So the nurse has gone to someone else and is asking for assistance. So that being said, we're going to provide that assistance and assist that nurse in learning how to work with the family. So the answer is C. Oh, my screen is frozen here. See if we can figure out what the issue is. Well, please bear with me while I try to figure out what's going on here. Oh, it looks like I was able to get it to move. Let's see if we can go back to 2. I don't know why I'm having so many issues today. Okay, here's 2. The healthcare team believes that a patient with multiple organ dysfunction syndrome will not survive and is dying. Which of the following is the most appropriate action at this time? A, avoid a discussion of death since it's upsetting to the patient's wife. B, ensure the patient's wife understands the availability of palliative care at the end of life. Refer the family's questions to the attending physician. Portray the hopelessness of the situation so that the patient's wife accepts the reality of the situation. Okay, so avoiding a discussion of death since it's upsetting, that wouldn't be appropriate. Ensure the patient's wife understands the availability of palliative care at the end of life. So in B, we're offering some resources to assist. Refer the family's questions to the attending physician. No, that wouldn't be appropriate. Portray the hopelessness of the situation so that the patient's wife accepts the reality of the situation. Well, that's not really going to help the wife, because if she doesn't want to believe it, all the hopelessness that we portray is not going to work. So the answer here is we realize the family member is not doing well. And so we want to get them the resources they need. So the answer is B. Okay, 3, upon entering the room of a patient who is receiving mechanical ventilation, the nurse notices that the nurse tech allowed the patient to remain supine and did not elevate the head of bed to at least 30 degrees before leaving the room. The best response would be to elevate the head of the bed and A, mention the nurse tech's omission to the charge nurse, point out the omission to the nurse tech later in the shift, advocate for policy changes related to nurse tech's responsibilities, or D, explain the rationale for the elevation of the head of bed for a patient on a ventilator to the nurse tech. So this is really about integrity, this question for me, and it's really about things that I like to call take the mail to the right address. We've identified an issue. It is also one of our pieces in caring practices is to teach. So mentioning the omission to the charge nurse, that's not really going to change anything. It's just kind of deflecting the issue to someone else. Point out the omission to the nurse tech later in the shift. Well, that we're missing some timing there that may continue the whole shift, putting patients at risk. So that's not the answer. Advocate for a policy change related to the nurse tech's responsibility. That's not really going to address the issue right at hand. So D is the answer. We're going to explain the rationale to the tech for the elevation of the head of bed, and so that they can understand the importance or the why of why it is important for them to carry that out. So the answer is D. And I don't know why my computer keeps freezing up. All right, folks, it looks like, unfortunately, my computer is frozen and I can no longer move through the questions. It's about 9:30 now. I know we have about 30 minutes, but I seem to not be able to move my screen. Let me just try a couple more things. Okay, well, unfortunately, I'm going to have to stop here. So what I will do is make sure that you have all of the handouts available. I will get those to Barbara so that we can get those out. I have about 25 practice questions, I believe, here. So what I will do is not only get you the practice questions, but get you the answers with the rationale so that you will have these to review and to work on to help understand. Again, I apologize. I'm not sure what my issue is right now, but anyway, so I'm going to conclude for today. I am so grateful to have had this time with you and look forward to getting this information out to you. Anybody have any questions? Let me see if I can open.
Thank you.
You're welcome. Again, I am so sorry, but I will get the information out to you guys. You guys
Thank you.
have a good day.
Too.
Thanks.